You're listening to the O&P Check-In, an SPS podcast.
This podcast brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community.
Thank you for joining us. My name is Jacki Green. I'm a marketing specialist at SPS.
And I'm Brendan Erickson, regional sales manager here at SPS.
Welcome back to our listeners. If you're new to the O&P Check-In, here is what you can expect. In each episode, we provide a quick SPS update and discuss hot topics in O&P with leading professionals in the industry. Before we get started, let's hear a word from our sponsor.
Knit Right Soft Sock prosthetic socks stretch and recover to conform to the limb, making them comfortable next to the skin and shrinkage resistant. They are made with moisture wicking fibers to keep the wearer dry and inhibit odor in the sock. Explore Knit Right soft socks on the SPS website at spsco.com.
Thanks, Knit Right. So we are excited to announce that the 2022 SPS O&P Technician Scholarship is now accepting applications.
That's right. One O&P technician student will be awarded $2,500 based on a written or video essay submission and leadership qualities.
Yep, the deadline is October 14th. So if you or somebody you know would like to learn more about the application process or the essay prompts, visit spsco.com/scholarship.
Yes, calling all tech students. All right, let's get into it. We're excited to have Kurt Collier on the show. I'm sure many of you guys know him. He's been around in the O&P industry. But Kurt is the Vice President of Prosthetics at Integrum, an adjunct faculty member at the University of Maryland, and an ABC certified prosthetist. He has been in the industry for over 30 years and has held executive positions at Freedom Innovations, OSER, and FlexFoot, and has practiced clinically in multiple states. From winning bronze at the Atlantic Paralympic Games to founding the nonprofit Professionals Helping Amputees Train, Kurt has had an incredible career in the O&P industry. We're so thrilled to chat with him today. Welcome, Kurt.
Thank you, Brandon. Good, great, and happy to be here.
Thank you so much for joining us today. Super exciting. So for our listeners, can you tell us a little bit about your background and how you got started in this industry and just give us a little overview about yourself?
Sure. So years ago, I was trying to get out of college, and the shortest path out of college was to become a biology teacher as I was studying biology. It was that summer after I graduated from college that I was a victim of a hit and run accident while bicycling. As a result, I lost my leg below the knee, opening myself up to an entire profession and field that I didn't even know existed. More importantly, it was a field that involved me directly. As such, after some initial fittings and not being a very compliant patient, and of course, blaming my prosthetist, I decided that I needed to go back to school and learn more about me. So in 1992, I went to Northwestern Prosthetics program, completed their certification program.
That's great. And I'm sure you're the only person that has ever blamed their prosthetist, right?
Exactly. I'm sure. Now, but I was very fortunate that my, when I look in hindsight, that it propelled me into a field that I never really intended to go into. I simply just wanted to go learn more about how to take care of me. And after investing that time and money at Northwestern, I decided to get into the field and became certified. And what an amazing profession. As you mentioned, I've taught at the University of Maryland now for 16 semesters. And to be able to introduce the field of prosthetics to a group of students that didn't know it existed or didn't know it could be as fun or as rewarding has been fantastic. And so I'm very fortunate to have, entered into the field and remained in the field. And over the years, it's never let us down, I don't think, and it's continuing to advance forward. So I'm happy to be a part of it.
Well, and we're happy to you. You're kind of a rock star out there. I'm sure all of our listeners have either seen you present at a Academy or AOPA show, or even locally, or even for the various vendors and manufacturers that you've worked for. So thank you so much for being here. But let's dive into the topic today. Direct skeletal attachment systems, also known as osseointegration or OI. What is it, and how does it compare to conventional socket systems?
Well, bone anchored prosthetics has been around for actually longer than some of us are aware. The company I work for, Integrum, was the founders of osseo-anchored prosthetics, and they were founded in 1998 as a company. A lot of research has gone over the years to make it a viable option to directly anchor our prosthetic devices to our skeleton. Currently, the OPRA system has an FDA approval for the transfemoral patients. And so that's where most of our focus has been. To watch and to be a part of this change in our profession has been rewarding and amazing. To directly load through the skeleton, right? We're returning to a closed chain system as Mother Nature intended us to be, right? So we're no longer fighting volume changes. We're no longer fighting suspension. We're no longer fighting dermal issues created by a socket. It is absolutely fascinating, and I'm honored to honestly be a part of it.
Hey, quick question before we move on. But Kurt, I mentioned osseointegration, and you're saying osseo-anchored. Am I incorrect? And can you clarify the difference?
For the record, so osseointegration is the term. The OPRA system, when we went to the FDA and the FDA came back to us, they asked us to not use the term osseointegration because that's for dental, right? Mm-hmm. So OI, osseointegration, bone anchored, osseo anchored, it's all the same thing. And it's really, it's an issue. I mean, everybody else gets to say osseointegration, but the FDA has told us that we can't, right? So that's a great question on your part. So I could say OI if you prefer.
Brendan, if you hadn't caught that, I wouldn't have even made the connection that you were using slightly different verbiage there to describe what osseointegration or not osseointegration. Moving on from the difference in the verbiage, what is the reception? What has the reception been for OI, and how has it impacted patients?
That's a great question. So, and as I shared, OI moving forward is relatively new, right? And new things in the field of prosthetics comes with a lot of emotion and a lot of fanfare. And so as we've looked at, OI of recent, it's really been the patients that have identified it through social media, through websites, right? Through the internet, and have really developed in part the field, right? Because they were the ones that identified that it was available and they wanted to go pursue it. With that said, when we look at the prosthetist and the clinician, there's a lot of newness, right? So it's so new that there's a lot of information that we as clinicians never received in school, right? Not only did we never receive it in school, if we did receive it, it was maybe a lecture, right? Or half a lecture. This is a whole manner of how we take care of patients. We did a whole, when we were studying in school, we did several weeks on transfemorals and how to do the sockets for transfemorals and how to fit them, how to align them, right? So to think that we introduced this new aspect of our field of prosthetics with OI, it's not been embraced because we're not necessarily as clinicians fully informed. And that's been a little bit of a challenge in trying to make people embrace it, because we don't know about it, and our patients may or may not know more about it than we do as clinicians, because we don't know if their information is accurate or is it hearsay, right? So as a clinician is being asked these questions by a potential patient or by their patients, maybe they do or they don't know, and they don't want to misinform their individuals. So as a result, I would say, it's been very well embraced by the individuals that are pursuing it. But at the same time, the clinicians are very hesitant. And I think a lot of it is also, a lot of the hesitation is because of a lack of understanding, as well as the perception that financially the removal of a socket can impact the ability to generate revenue for your business. Right. But again, that's another opportunity to educate, right? Because the amount of time that we spend in caring for these patients don't involve socket fabrication or socket fit. So there's a lot of education to be done, but it has been embraced by the patients, and it's moving out not as fast as a company would like, right? But it's evolving into a profession, and it's a change of a profession, a dramatic change. As clinicians, we wanted to learn to make sockets. Our whole schooling was on making sockets. OI is the elimination of the socket, right? So you can see that paradigm shift creates hesitation to embracing it. But it is an amazing outcome when these individuals have the procedure, complete the rehab, and give the time.
So this is kind of a rogue question. Is there a lot of emphasis being placed on educating at the university and program level then, so that the incoming prosthetists into the industry are understanding more of how to utilize the new technology, how to utilize OI instead of what's traditionally been done?
A great question. And we're trying to, as a company, we're trying to do that, right? But again, frankly, we're a startup company. So our resources are limited. And as we try to go find patients and train the surgeons and work with the PM&R docs that manage the rehab and train the physical therapist and train the prosthetist that are taking care of patients that are created today, right? Or last week or last year, to then be proactive and get to the schools, sometimes is a bit of a struggle. But we do want to do that. We have begun providing some of those lectures. We do get to the state meetings, right, to try to educate through the state meetings, and we participate, in events as such that SPS is hosting to help us again find avenues to communicate to our profession that there is a change, and then help people to understand what that change is and the differences that exist.
So Kurt, I'm going to ask you kind of a general and a specific question at once. You mentioned Integrum, and you also mentioned somewhat of a sea change from traditional socketry to maybe not having a socket with osseointegration. Can you give us a timeline of when this started and when you think that sea change would happen? And specifically, what does Integrum see as their goal within that timeline?
Well, I mean, Integrum is a publicly traded company, right? So as you understand, the investors want you to grow as fast as possible. But we have a profession that we need to move this into. We have, hospitals that need to be opened up, surgeons that need to be trained. So, right now we've continued to grow. We're right now in the United States. We have, we're provide the OPRA system in 12 of the top 20 hospitals across the United States, with hospitals such as Walter Reed for our military patients, as well as hospitals such as Johns Hopkins, or the Mayo Clinic or USC, and as well as Duke. All premier hospitals that do provide the procedure. There are you can look on our website. We have more. But we continue to open up centers regionally, right? So this is accessible to everybody across the US. When I first started with this company, we had two. We had one at Walter Reed, and we had a civilian center at UCSF in San Francisco, University of California, San Francisco, right? We have far more than that now, right? So it's continuing to grow, and it's continuing to establish itself within the marketplace in the US. to the point now where we have a new procedure that's also being reimbursed by the insurance company. So the majority of the insurance, we have patients from just about all of the insurance companies as well, that are authorizing for the patients to have the procedure.
Yeah, I remember the first time I heard about it, people were traveling overseas to Australia to have the procedure done, and how much it's grown now to being in all of those institutions and hospitals. That's pretty awesome. So congratulations on all the great work that you're doing. But what type of patients would benefit most from this type of procedure?
That's another good question. So with the FDA, when we're an FDA approved product, the OPRA system for transfemorals. And so a part of that product labeling is we had to identify who the product is for and who it's not for. So essentially, it's not for individuals that have vascular disease or uncontrollable diabetes. From there, traumatic amputee, congenital amputee, or an individual that had sarcoma, had cancer, right, could be considered as a patient. We look for individuals that have, short residual limbs, bilaterals, people that have invaginated scars that can make wearing a prosthesis a challenge in that region. Individuals that have skin grafts where the dermis is challenged, as well as individuals that potentially have issues with suspension due to hyperhidrosis or excessive sweating. So that's what's identified, in our product labeling for these patients, and it's really easy, right? Because we've gone and trained all of our surgeons on who the candidates are. We've trained our surgeons on how to do the surgery. But with that point said, is we as clinicians, we just need to be able to know who to refer our patients to. We don't have to make that decision. It's kind of beautiful. We don't have to be the heavy or the bad guy. All we have to do is know the avenue in our local region to direct our patients, in to see the doctor. And then the doctor can make that choice. And they'll make that choice based on sound medical decision, a psychological, decision as well. And then, of course, they'll have to, financially get it through their insurance company. But all of those pieces are not on the shoulders of the prosthetist, right? That's all on the shoulders of the doctor. So if we have a patient that we know is not going to make us look bad, what I mean by that is, we don't want to take a brittle diabetic that should not waste the time at the doctor's office and send them over there, because then we look bad as a referral source. So outside of that, just either congenital, a cancer-related patient or a traumatic patient, let the doctor make the determination.
So when it comes to OI, what improvements or new technologies can patients and clinicians expect to see in the future?
Well, moving forward, so when we're anchoring a prosthetic device to the bone, and we place a fixture in the medullary canal of the bone, and then we anchor an abutment that protrudes from inside the body outside of the body, we have a very unique pathway inside of the body. So we have products that have been developed in Sweden. They're not available here in the US. And several patients that have received them. If you think of that abutment, the part that sticks inside the body and outside of the body, if we would take that simple abutment out, just 100% titanium, and we replace that abutment with one that has wires at the proximal aspect of the abutment, the part that's up in the body, right? And we take those wires and we pull them through the fixture. We create an osteotomy, or a hole in the bone, and pull those wires through the bone and directly anchor those wires into muscle bellies. And then those wires connect to an abutment, a special abutment. The part that's sticking out of the body is like a plug. So you connect the abutment into what we call an ALC, an artificial limb controller, or basically a computer. So now you're able to take EMG signals directly from muscle. You don't have to use surface measurements to find your EMG signals, right? So you don't have to make a super strong contraction to get through your skin to be picked up by a sensor. The sensor is right in the muscle itself. So there's no crossover signals. So if somebody's working above their shoulders because they're not wearing a harness, right? And now because they're osseo-anchored and they're trying to open and close their hand to grab something and they're firing off their deltoid muscle, there's no crossover signal to open and close the hand, right? Because the wire or the source of information is coming from inside the body. So there's no distortion, right? It's absolutely amazing where this technology already is, right? It already exists. We have, multiple patients. We're working with other key research institutes to develop this for lower limb control mechanisms as well, to flex and extend the knee and the ankle, right? So there's work going on up at MIT with Hugh Herr that complements all of this, right? So it's a fascinating avenue, and it's, the upgradability is a true credit to Dr. Brannemark that developed this whole Oprah approach, because he's also a mechanical engineer and he built a system that's modular and upgradable within itself. So if you receive the implant, you haven't shut yourself down to future technologies.
This is another rogue question.
I got one too. So
Okay.
You're doing great, Kurt. It means you're doing really well.
So in your mind, with in the industry, prosthetists being kind of concerned with this new technology, but the real potential for patient care and improvement in technology and access, how do you, and you're talking about the doctors making the hard call decisions and everything, how do you see everybody in your perfect world working together to kind of really implement OI and make it more accessible and grow it so that the right patients who are potentially perfect candidates for this have, I don't want to say immediate access, but have the best team supporting them to do that? What does that process, I guess, look like in your mind, if there's even an answer for that question yet?
Yeah, no, it is a challenge, right? Because we want people to be educated. If you're educated, you're not necessarily threatened by it. To the point, right? Prosthetics is provided by prosthetists because we know our products, we know our patients, we know this population, right? We're masters of gait. We know gait, right? We know how to optimize componentry to match a patient, not only in selection, but in how we set it up, right? So the prosthetist has a key role, right? And I do think it needs to be embraced, right? Because it's moving forward. This whole osseointegration, OI, the Oprah system all starts with the hospitals and the surgeons, right? They're the ones that want it and they're going to do it. And the patients have identified that it's valuable, right? So it's coming forward. We're FDA approved. As I said, we're in 12 to 20 hospitals. It's here. I've had clinicians still say, well, it's coming, maybe it'll be a great thing when it gets here. It's here, right? So with that said, if the clinicians embrace it from that perspective, meaning that we know amputees, we know that population of people, we're masters of gait and we're masters of the componentry. Physical therapists don't want this, right? They can do it. They've had the ability to do prosthetics for quite some time. They still don't, right? It's because it's hard, right? And so they're the rehab individuals, right? So you got to have that rehab person, and then we have the physicians, right? We have an orthopedic oncologist typically that, manage the implant placement into the bone, right? And then we have a second surgery, which is typically done by a plastic surgeon that manages the soft tissue, right? Because the Oprah procedure does a lot with soft tissue that other implants don't. So we need the skill set of a plastic surgeon. Once the patient in that hospital, right, is evolved, we've got, physicians involved, right? So we need somebody to manage the patient throughout the rehab. And that's the PM&R doctor, physical medicine and rehabilitation, right? So we work with those physical medicine and rehabilitation specialists to take the patients after the physicians are finished.
Hey, so Kurt, one question on the top of my mind that What is the role of a prosthetist once somebody has successful OI and say it's 6 months down the road? I mean, you're still fitting them with feet and knees.
They're going to come in and see you. They're going to need the axer, the connection device needs to be serviced. There's some interstitial fluids will get in there, some dirt and debris, right? So you're still seeing these patients. I think you see them just about as much, but you just don't have to fabricate a socket, right?
Right.
So you're not investing all of that. I don't say it very often, but there's information out there that's identified quality of life goes up by a factor of 10. I don't use that in quotes in lectures because that's too big. But when these guys get through this rehab aspect, it's fascinating to see them and talk to them. Their quality of life is just, they don't worry about the suspension. They don't worry about it falling off. It doesn't take them they put it on in 10 seconds.
Yeah.
Right. You got elevated vacuum double wall sockets, right? That takes 5 minutes and you may put it on wrong. You put it on the same way every time. So what I've learned from these amputees, right, is an amputee learns instinctually where, if they move their limb, they'll break their seal, right? And so excessive adduction, I can't go past here. And they don't even think about it. They just know where it is, right? And so all of a sudden you put them in OI, right? And now they never, ever have to think about a limitation of flexion, extension, adduction, adduction, somebody bumping their legs, somebody pushing it off. And it's like the best thing for the first 2 months. And then if you get to like 4 months later and ask them what the best thing is, they don't talk about suspension anymore because it's so ingrained in their body. They forgot it. Yeah. And you're like, dude, you told me 2 months ago suspension was insane. He goes, oh my gosh, I forgot all about it, right? but that's just like a testament to how radical of a switch this is. So once we get to physical medicine and rehab doctors, right, they typically identify the physical therapist. Now, sometimes the patients skip the PM&R doctors and go right to the physical therapist. And that's the nature of our profession. And we're accustomed to that too. But we really want to work with all those individuals. We want to make sure the surgeons are trained, right? And their process is refined. We want to be able to, both the plastic and the orthopedic surgeon, we want to be able to train the PM&R docs so they know the overall scheme of what they're managing. And then they have typically the physical therapist that they continue to provide oversight. So we at Integrum, we provide training to all those parties, right? And with that said, then we know that our patients are in really good hands. We also know as clinicians that sometimes our patients believe they understand what they need to do, right? So when we surround them with this team, and it truly is the team approach that's going to give us these outcomes, that's going to continue to let this proliferate and grow within the marketplace. And last thing I'll share on this topic is, where can it go? Well, the FDA has actually identified that for the transfemoral level, it has so much potential that you can start with this as a primary aspect of amputation. So no longer do you need to be fit with a socket for a period of time before you become a candidate for osseointegration. Right. So if the physician evaluates the patient and thinks that the osseointegration is a better pathway for this patient, they can start right there. Now, that hasn't occurred very often to date, right? But the idea that osseointegration is a primary pathway of care, fascinating, and holds a wealth of potential. Very exciting. I have the joy in providing lectures to the audience to share. If you're an inventor, it's a great time to be an inventor. So if we just think about the use of a prosthesis on a transfemoral amputee, for them to move the lower limb componentry, bend a knee, you need to move your femur inside the socket that compresses the soft tissue up against the socket wall, and then the pressure on the socket wall then moves your componentry. In OI, the moment you move your femur, all those moments, all those forces go directly into your prosthetic device. So that's a much higher force. That's a much more instantaneous force to manage. So just from that perspective of knees, the knees weren't built under that design, right? There's a little bit of lag time. It's small, but it's considerable when it comes to movement, right? And human reaction. So there's a wealth of opportunity to make products hardier, to make them much more responsive. If we just take a look at the feet, right? When we're loading that foot product, the moment of all that force going into the system, there's no dampening, there's no compression of the soft tissue. So those management of those forces are up. So, potentially we're looking at an excessive rate of wear and tear. Not to mention, these patients wear their prosthesis 3 times more on average than a typical transfemoral patient does. Most of my patients tell me when my eyes are open, my leg is on.
That's incredible.
It's insane. I love hearing it. And so as such, just that the durability factor is going to create opportunities for new prosthetic components. The responsiveness, the capability of managing your patient throughout different activities creates a wealth of opportunity, for inventors and designers to develop new product.
Too bad I'm not smart enough to be an inventor.
Yeah, me either. I can just tell you what I want.
Okay, well, Kurt, this is amazing. Is there anything else you would like to add that Jacki and I couldn't think of on the spot?
It's a tough one. No, I just like to share how much I appreciate the opportunity to, further, OI into the U.S. marketplace as an option, right? We have, as a prosthetist, we have our patients that we want to provide the best care for. And I look at OI as something else in our toolbox that we can now consider as a viable option, not as a novelty that we read about or saw in a magazine. And as such, I think as clinicians, there's a responsibility for us to understand it so that we can continue to provide the highest level of care to our patients. I appreciate the opportunity to share this information. I'm grateful for SPS for helping out. It was a great show. So thank you.
Thank you so much for joining us. Seriously, this is fascinating. All right, if you would like to learn more about OI, follow the link in our show notes. Thank you so much, Kurt.
You're very welcome. Thanks for having me.
Well, there you have it. Thank you for listening to the O&P Check-In, an SPS podcast.
If you like what you hear, hit the subscribe button on Spotify, Apple Podcasts, Stitcher, or wherever you listen to podcasts. Please rate and review the show to help fellow O&P professionals find us.
We'd also like to hear from you directly. What topics do you want us to cover? Do you have any burning questions? Email us with your thoughts and feedback at spspodcast@spsco.com. See you next time.
Bye.
Bye.